This presentation is for the 2018 protocol updates for all the West Virginia EMS providers. This presentation is brought to you in collaboration by the West Virginia EMS Advisory Council, the West Virginia Office of Emergency Medical Services, and the EMS Department of Pierpont Community and Technical College. New for 2018 is going to be the drug formularies. This is going to be a reference sheet for all the medications that can be administered by West Virginia EMS providers. As you see in the picture, there will be a similar sheet for all the drugs that can be administered, and you see in the top right this can be administered from EMT to paramedic, so all the drug sheets will list at what levels these medications can be administered. So it includes such things as overview of the medications, indications for giving the medication, contraindications, certain precautions, side effects, how to administer the medication, how they're packaged and supplied, and various others. The narcotic dosing had changed in the 2017 protocols, but there's been some minor clarifications for 2018. The narcotic dosing applies to protocols 4202 for chest pain and acute coronary syndrome, 4213 right ventricular myocardial infarction, and 4902 pain management. This applies to patients over the age of 55, where essentially the dosing of the narcotics is cut in half. The language in this just changed a little bit for some clarification on the dosing. So over the age of 55, for morphine, that's 1 milligram slow IV push every 5 minutes up to a total dose of 10. And for fentanyl, that's 0.5 micrograms per kilogram up to a max dose of 100 micrograms. Any additional dosing of morphine or fentanyl requires MCP order. New for 2018 is major changes to spinal immobilization. The previous protocols of 102 and 103 and the 4000, 5000, and 6000 series protocols for EMT, ACT, and paramedic have been combined. So in the previous protocols that were kind of algorithm based, those have been removed and combined. So all these changes have come out of some recent research on the use of long backboards and mobilization in the pre-hospital environment. So just as an overview in the top here, backboards are not the standard of care in most cases of potential spinal injury and have not been shown to provide any benefit for spinal injuries. Backboards may be appropriately utilized as an extrication device and or tool to carry non-ambulatory patients. Neurological exam is mandatory in patients with potential spinal trauma. So as first, just an overview, you go through and you do your universal care and patient assessments based on those respective protocols. You're going to identify any risk of spinal column or spinal cord injuries and prevent or reduce further spinal column or spinal cord injury through application of appropriate evidence-based immobilization. So we're going to prevent and reduce those secondary injuries of improper use of backboards. You can use a long spine board to transfer the patient to stretcher with minimal spinal movement. Then you're going to want to remove that device. So if you're using that backboard to only transport the patient to the cot, that backboard should be removed afterwards, with the exception of D1 through 4 here. So if the backboard is being utilized as an element of splinting or immobilization, such as splinting multiple long bone fractures, leave the backboard. If the patient's at risk of vomiting but unable to protect their own airway, so if they're on that backboard, you need to use it to tilt them to the side. In the event that they're unable to protect their own airway, leave that backboard. Cases in which the patient's agitated or unresponsive, leave the backboard. If removal of the backboard is otherwise going to delay patient care or transport, leave the backboard. Next, in Article E here, for extrication of a patient to the stretcher. If a patient does not meet the criteria for C-spine mobilization and has no other injury, including thoracic or lumbar injury, that would preclude standing or ambulating, patient may self-extricate with assistance to a waiting stretcher. Patients who are on the ground with C-collar applied, who have altered mental status, GCS less than 15, neurological signs of injury, and are unable to stand from sitting position should be positioned and immobilized to a long spine board or a scoop stretcher for extrication to the stretcher. Treatments and interventions. Apply a C-collar if a patient is assessed and there's suspicion of cervical injury. If it does not cause increased agitation or pain, apply a properly fitted C-collar. Suspicion of cervical injury includes neck pain, tenderness on palpation of the spinal column, abnormal mental status, including agitation or neurological deficits, or any evidence of drug or alcohol ingestion. Apply full immobilization if the patient is assessed and exhibits with any of the following: abnormal sensory motor exam, abnormal findings such as paralysis, loss of sensation, weakness, or loss of sphincter control or urethra control. Distracting injuries that produce pain that may distract the patient from the pain of the spine injury. Complaints of pain or tenderness on examination of the spine, including palpation of the entire spine and with range of motion. Patient reliability is questioned, such as the following: if they're intoxicated, in the elderly, young, altered mental status, chemically altered, or those patients that you cannot adequately perceive or communicate with. So some exclusion criteria. If there's no history of injury consistent with spinal injury, patients with penetrating trauma to the chest, abdomen, head, neck, or back, these kind of patients might be harmed further by immobilizing on a spine board. Patients with non-traumatic back or neck pain related to movement, position, or heavy lifting. Some precautions and considerations. Cautions should be exercised in high-risk patients, such as those over 65 years or less than 3 years of age, as those spinal assessments may be less sensitive in those age groups. This criteria in and of itself is not a factor in the provider's decision-making process to immobilize or not. Consider airway adjuncts if needed to maintain an adequate airway. There's no evidence that says the standing takedown technique is beneficial or appropriate. Ambulatory patients should simply be eased to a sitting position on the stretcher without the use of a backboard. Use care in those patients that have spinal abnormalities such as kyphosis. Also new for 2018 is Protocol 4112 for tranexamic acid, which is optional. Tranexamic acid, more commonly known as TXA. TXA is an antifibrinolytic that inhibits the activation of plasminogen. So basically, TXA is used in early administration that has also shown to reduce mortality and death secondary to trauma, more specifically hemorrhagic shock. So the indications for using TXA is known or suspected hemorrhage after crush, blunt, or penetrating trauma in persons over the age of 18 with sustained hypotension, systolic blood pressure less than 90, and sustained tachycardia over 110. So definitely signs and symptoms of shock. And with that time of injury less than 3 hours from the initiation of TXA. Initiate transport to a definitive trauma center that has the capability to administer and or continue TXA. Contraindications with TXA is time being over more than 3 hours since the onset, known pregnancy, and known allergy or hypersensitivity to TXA. Dosing administration is an MCP order and also for destination determination. The loading dose of that is going to be an IV infusion of 1 gram of TXA diluted in 100 milliliters or a 250 milliliter normal saline infused over 10 minutes. A maintenance dose is going to be the same thing but infused over 8 hours. So a note that if patients are taking the beta blockers, that reflex tachycardia may not be present due to that beta blocker response. These patients, while in traumatic hemorrhagic shock, may present with hypotension and that normal heart rate. For protocol 303 of the 4000 series, so for paramedic, for the pulmonary edema protocol, the systolic pressure for administration of nitro has been changed to 110. Previously, the systolic pressure had to be 180, and it's still that you give the nitroglycerin after 5 minutes of the use of CPAP. As long as that pressure is above 110, you can now give nitro for that. And for paramedics, Lasix is still a standing order. For the 5000 series, for the ACTs, that same systolic pressure is there for the 110 5 minutes after initiation of CPAP. And still, Lasix is an MCP order. For the EMTs, 6303, that systolic pressure has also changed to 110, and that's 5 minutes after initiation of CPAP. In protocols 4411 and 5411, pediatric diabetic emergencies, the addition of oral glucose has been added to those protocols. And remember, for the ACTs out there, that dextrose and glucagon are still MCP order. Protocol 4501 and 5501, allergic reaction anaphylaxis. That's for the ACT and paramedic. A couple changes with this one. The MCP order for patients over the age of 55 has been removed. Also, now it is standing orders for ACT and paramedic to give the epinephrine as standing orders for adults over the age of 12, and that's still an MCP order for EMTs. And also note that the administration of Benadryl is only for paramedics. ACTs are not allowed to administer Benadryl. That is for paramedics only. The change to protocol 4607, chemical restraints, is for paramedic only. With this protocol, the addition of ketamine in the instance of excited delirium has been added as an option. So if that patient is exhibiting extreme psychotic behavior or excited delirium is suspected, you can administer ketamine as a single dose, 5 milligrams per kilogram IM or IVIO at 2 milligrams per kilogram. So again, that's 5 milligrams per kilo IM, or if you already have an IV or IO, that's 2 milligrams per kilo. Also as a note, if suspected or known presence of benzos in the patient, consider half dose of the ketamine to minimize any kind of respiratory depression. Ketamine has also been added to protocol 4902 pain management, and this again is for paramedics only as an option. So for non-cardiac related pain that is not relieved after administration of morphine or fentanyl, you may administer ketamine 0.2 milligrams per kilogram to max single dose of 20 milligrams, and that's slow IV push over 1 minute, or 0.5 milligrams per kilogram IM intramuscularly. Any more doses of that require MCP order. So let's talk now a little bit about ketamine. Again, ketamine is only to be administered by paramedics. The onset of ketamine is within about 3 to 5 minutes on average for intramuscular, and less than 1 minute, generally a pretty rapid onset with IV administration. This is much faster than Haldol and Versed and other means we use to sedate, so that's kind of why ketamine's coming into play on the forefront, is to have that quicker sedation for those excited delirium patients. The duration, the action of it is about 10 to 20 minutes. Some studies and some research show that the intramuscular route may last a little bit longer, upwards of almost an hour to be fully in the system, but only having sedative properties to about 30 minutes. But on average, most documentation shows 10 to 20 minutes for true sedation. And of those patients being administered ketamine with the same dosing that is listed in the West Virginia protocols, it does achieve the desired sedation rate of about 95% of the patients, and that is averages released by several studies over the past several years in the pre-hospital and hospital settings. Ketamine generally doesn't have any hypotensive effects, unlike opiates, where actually it may increase the blood pressure. Those studies have shown anywhere from a slight increase to maybe a 25% increase. One of the a large noticeable issue with ketamine is the topic of emergence reactions or deliriums. So what this means is once the patient becomes no longer sedated, they come out and may be experiencing a new, different kind of delirium, hallucinations, having more psychiatric behavior different than what they were when they initially got sedated. So generally with those, it's short term. Most cases show those instances that have happened are within just a few hours, but there are few cases lasting up to about 24 hours. And a lot of the research that's out there, that's showing anywhere on average of about 10% of the patients that are given ketamine for those excited deliriums do come out with those emergent reactions or those deliriums. So once they become unsedated, they may require some additional sedation by benzos. So if you give a patient ketamine, you get them sedated, and they come back and are having an emergent reaction that's not an excited delirium, then you may have to administer Versed to sedate them, calm, and relax them. The biggest issue, though, with ketamine is the need for aggressive airway management. And the research and the studies show anywhere up to 50% of the patients administered ketamine need aggressive airway management, including ventilation assistance or intubation. And a lot of the research that's out there for pre-hospital wise, it's showing anywhere, up to 50% of those patients needing intubated, on average about 30-40%, but upwards of 50% in some studies. But only about 4% of those patients are actually getting intubated in the pre-hospital setting. Most of these studies are coming out of the hospital setting to where they're intubating about 40% of those patients, or upwards of 50. So keep that in the back of your mind that you need to monitor their waveform capnography to be evaluating their respiratory drive to make sure once you've given that ketamine that they're not developing respiratory depression or apnea. Some other less common side effects are hypersalivation, laryngospasms. Even though ketamine is known for being a bronchodilator, it can still cause some laryngeal spasms, and nausea, vomiting, and emesis. So you can see administering ketamine, you're going to have to probably be very aggressive managing that patient's airway. Also new for 2018 is being able to access PICC lines. This is for ACTs and paramedics only. So those PICC lines are commonly placed into the AC fossa. Also to know that those PICC lines are generally flushed with heparin to maintain patency, and so need to remember we need to aspirate out 5 milliliters of blood from the PICC line prior to use. So you take your syringe and you aspirate 5 milliliters of that blood out, because you're going to suck out that heparin too, so we don't shove that heparin on through. So whatever you use to aspirate, you're going to discard that syringe. So indication for using a PICC line, this is not to be used just for prophylactic access. This is going to be if there's need for immediate vascular access in life-threatening emergencies. If there's IV fluids or medications that are urgently needed and peripheral intravenous access cannot be established in a timely manner, and the patient exhibits one or more of the following. If they have a GCS less than 8, if they have respiratory compromise, if they're significantly hypoxic, less than 90 after oxygen therapy, or if they've got a respiratory rate less than 10 or over 40, if they are hemodynamically unstable, if they are hypotensive with the systolic pressure less than 90. That PICC line access may be considered prior to peripheral IV attempts where successful rapid peripheral IV placement is doubtful, such as the following situations: in cardiac arrest due to medical reasons or trauma, profound hypovolemia with altered mental status, patients in extremis with immediate need for medication or IV fluids, such as that patient in status epilepticus, impending arrest, etc. Patients or patient's caregiver request the use of the PICC line and accept the risk of complications including infection, catheter damage, and emboli. So if that patient or the caregiver just requests to use that PICC line instead of doing a new IV. Contraindications for accessing that PICC line: the inability to aspirate or infuse through the catheter. So if you're unable to aspirate that 5 milliliters out, don't use the PICC line. If the catheter is located in any place other than a patient's upper arm, and need for rapid fluid resuscitation. But worry about that because rapid boluses can damage those PICC lines because they cannot handle lots of pressure. So the procedure to use it: always don BSI. If there's a needleless port on the distal end of the catheter, do the following: scrub a port with an alcohol prep pad for at least 15 seconds and allow to dry for 5 seconds. So clean that port really well and allow the alcohol to dry. Using a 10 cc syringe, you're going to unclamp that PICC line and then you're going to aspirate 5 milliliters of blood through that PICC line. It should draw freely. If it does not, remove the syringe and do not use the catheter. Once you do aspirate that blood, remove that 10 milliliter syringe and discard the 5 milliliters you have aspirated. Attach another 10 cc syringe with a flush and gently flush out that line. Do not slam it, do not pressurize it, a slow push. Never use smaller than 10 cc's. If a line does not flush, remove the syringe and do not use the PICC line. If the line flushes, remove that syringe and attach the catheter to the end of IV tubing and begin the infusion of your fluids. Adjust the rate as needed. Administer medications through the IV tubing port if indicated. IV maintenance fluid must be administered to keep line open during that transport, so be sure to at least keep it as a KVO. If there's a cap needle port on the tip of the catheter, do the following: scrub the cap, same way as you do if it's a needleless port, 15 seconds, allow to dry for 5. Clamp that catheter tubing using only the existing clamp on the catheter and then remove the cap. Never allow a central line to be open to the air. You will cause an emboli. Attach that syringe, unclamp the catheter, and then aspirate at least 5 milliliters the same way in the previous steps. Remove that syringe, discard the 5 milliliters you've aspirated, and then repeat as a process before listed of using a 10 cc syringe. Flush slowly. If it is not flushing or you cannot aspirate, do not use the PICC line. Some notes and precautions: do not administer medications, flush or aspirate with anything less than a 10 cc syringe. Smaller ones are going to generate too much pressure and can damage that catheter. Do not attempt to re-inject aspirate blood as it contains clots. That heparin is sitting in the tip of that, so don't slam, don't flush it first. You must aspirate it and then discard a syringe, flush with a separate syringe. The maximum flow rate you're going to be able to do is 125 milliliters per hour in a 2.0 French, or 250 in anything bigger than a 2.0 French. So be sure to check the size of that PICC line before you determine your flow rate. Keep a patient's arm as straight as you can to avoid any kind of kinking in that PICC line or obstructing the flow. Ensure all those connections are secure, again, that you're not going to have it open the patient to an air emboli. Those PICC lines access the patient's central circulation, so the risk of infection is high. Avoid contamination as ports and connections while accessing. Be sure to be as sterile as you possibly can. Be cautious administering adenosine and dextrose, because we all know that adenosine, we do a rapid push, so that's going to generate a lot of pressure. And with D50, that's quite a significant push as well. So both of those can cause some overpressuring of that PICC line. So be very cautious with those. Then I just urge you to read in this protocol and look at all the potential complications and with their respective signs and symptoms that can occur from other complications of accessing that PICC line, such as air emboli, catheter emboli, arterial puncture, arrhythmias, nerve injuries, inability to advance a catheter, catheter malpositioning, infection, phlebitis, and difficulty in removing that PICC line. Protocol 9101, which is applicable to all levels, EMT, ACT, and paramedic, has been revamped a little bit. Basically, number 3 and number 5 have had some basic and simple rewording to those. So if they're pulseless apneic patients in an MCI situation where resources are required to maintain living patients and those resources are unavailable, and if resuscitation efforts pose a danger to the health and or safety of the rescuers, or the scene is judged unsafe for rescuers to continue providing care. Also, there is changes to 9102 for the cease efforts protocol. This is applicable to EMT, ACT, and paramedic as well. So a change to number 2, it previously only said pulseless and apneic, and it's been revamped a little bit to say patients remain in PEA or assistedly for greater than 20 minutes with no rhythm change, and that's confirmed in 2 leads, or if their end-tidal CO2 is less than 10 with high quality CPR for greater than 10 minutes. And in number 4, in those highlights you see there for BLS resuscitation, if it is proved unsuccessful and there's no ALS available within 30 minutes, or the patient's been confirmed pulseless and apneic for greater than 20 minutes with no shocks delivered from an AED. So that kind of ties into the ALS one of no rhythm changes. A change to Protocol 9105, also applicable to all levels, and this is the very last part of that protocol, and now there is the addition of using the hospital-based landing zone. So as you see in the highlights here, the EMS shall be permitted to utilize a hospital-based landing zone in cases where it is more practical and safer to do so versus a field-based landing site created at or near an incident scene. EMS shall develop an MOU with the facility prior to utilizing this protocol. So before you use it, LZ, your agency needs to have an MOU with the hospital. The hospital shall be contacted prior to use and permission granted by the facility to utilize the hospital-based landing zone. This shall assure that the landing site is clear and there is no other inbound flights due to arrive. So before you set up the landing zone, call the hospital and coordinate with them to make sure that it's clear. EMS shall not be required to enter the emergency room when simply utilizing the landing zone for EMS field operations. Subject to the following: medical command has been contacted and given a detailed patient assessment, and the hospital has been contacted and permission granted to utilize the facility. Thank you for watching this presentation. I just urge all of you to review these protocols thoroughly with your agency and your coworkers to ensure compliance with new protocol changes in your respective fields. Thank you.